Welcome to the Human Momentum Podcast. My name is Erik Schabert. I'm a doctor of osteopathic medicine with 12 years of medical education and more than a decade of clinical experience in family and osteopathic manipulative medicine in my background. My goal for this podcast is to sort through and distill down the confusing and often contradictory health information presented on social media into a format that you can use to become a more informed consumer of healthcare and partner with a health practitioner near you in order to get you the best possible optimized health outcomes. I named this podcast Human Momentum because I see getting people accurate information is giving them the tools they need to build their own momentum going forward through life and allowing them to get the best possible health outcomes and happiness. If this is your first time watching and you haven't done so already, please do hit that subscribe button. It really helps me get this information out to more people. And if you find the content useful or interesting, a like also helps us with the YouTube algorithm. And if you think somebody in your life could benefit from the information I'm presenting here, please do share it with them. If you have any questions or thoughts on the content of this video, please do drop a line in the comment section. I love interacting with my audience, whether you agree with the information I'm presenting or not. And with all that said, let's get on with today's episode. Welcome to this special healthcare policy edition of the Human Momentum Podcast. I want to begin by thanking all of you watching who have subscribed to the channel. We're closing in on 600 subscribers now, and that just doesn't happen without the help from all of you. And for those of you who are still watching right now and have not subscribed, what are you waiting for? It's absolutely free, and it really helps me get this content out to more people. So I'd really appreciate it if you could. I want today's podcast to feel like a interactive discussion of this important topic. I know I have a tendency to sound a little bit like a college professor lecturing students, and I want this episode to be more conversational. So if you have thoughts on this topic, please do share them in the comment section. I really want to get a bit of a discussion going on this topic and maybe have it something I can respond to with short videos for folks who have really good ideas. With that said, let's get on with today's topic. Something that is once again a major topic of discussion in American politics as we close in on the midterms. It's Medicare for all. The failure to extend ACA subsidies once again and limit access to Medicaid has put more Americans in the category of the uninsured with poor access to health care than we've seen in quite some time. I'm very much aware of this, and I'm aware that we have politicians like Graham Plattner running for Senate in Maine who are big proponents of Medicare for all as a potential solution to what ills the United States healthcare system. I'm not as confident as they are that this is the overall solution. I do think it would at least improve the situation of access to care. The United States lags most developed countries in healthcare outcomes. And one of the big drivers of it is that so many Americans just can't afford healthcare. Healthcare, additionally, is one of the primary sources for bankruptcy in the United States. And that just seems wrong to me as a physician. Well, I have a real set of opinions on this due to my personal experience working in healthcare. I graduated my residency in 2008, so I was on the ground practicing as the Affordable Care Act passed the legislature and was implemented. So I got to see firsthand the good, the bad, and the ugly of that particular piece of legislation. Obamacare is something that was a major political hot potato when it first started coming in, and a lot of Americans didn't like it as it was implemented. But over time, it really did grow on the country. And when the expanded ACA subsidies were rolled back as President Trump came into office and allowed to expire, we saw a major backlash from Americans. Because let's face it, we liked having healthcare through the Affordable Care Act exchanges that we could afford. And there was a big chunk of Americans that got exactly that. Well, something I do want to point out, though, that folks on the right have been strong to criticize the ACA with, those subsidies were originally part of COVID relief. The only reason we had the additional money going into the exchange was because of the COVID emergency. The government recognized we need more Americans to have health care because we have this virus spreading through the country, and they funneled money into it. But when the COVID emergency expired, there was a strong opinion among some legislators and certainly among some Americans that we should extend those subsidies indefinitely, but it didn't happen. And part of that is a failure of the original Affordable Care Act. If that money was so important to really make the act work, it should have been there in the first place. Well, something else I want to talk about is some of the criticism that was leveled at the ACA, otherwise known as Obamacare, that I don't think was even a little bit fair. And that is the ACA was blamed for rising insurance premiums as it was implemented. Now, as someone who had been working in healthcare, even through my residency, seeing a lot of outpatient visits and dealing a lot with insurance, I was very much aware that insurance premiums were ramping up considerably even before the ACA went into effect. And the fact that insurance companies were blaming the Affordable Care Act for a big jump in premiums after it was implemented, I thought was very disingenuous. When we look at the ACA, largely what it did is it made health insurance affordable for a lot of younger, healthier people who otherwise wouldn't have been able to afford it. So what you had is a situation where the government was paying part of the premium. We weren't getting a premium discount from insurance companies. They were actually charging pretty significant premiums still for relatively young, healthy people who were unlikely to utilize healthcare at a high rate. And so it doesn't make sense to me that a population where they were most likely making a pretty good profit would be caused to crank up premiums for people with employer provided health care and health insurance who may not be quite as healthy because they weren't quite as young. I think the reason this was done was because insurance companies can't look at the American public and say, hey, we have to crank up premiums because we want to maintain our profit margin and our bonus structure for our executives. And y'all are kind of overweight and unfit and have a lot of heart disease, diabetes, and other health problems that are costing us a bunch of money, which was, I think, a lot closer to the truth. So the idea of Medicare for all is that we are going to extend healthcare to every American, and it's going to be traditional Medicare. It's going to be a version of health insurance that is managed by the federal government and takes the profit motive for private corporations entirely out. And there is a thought that that is going to fix our healthcare system. Now, having been a physician who dealt a lot with traditional Medicare, I don't think that's entirely true. It is true that the administrative costs for privately run Medicare policies and for private health insurance are considerably higher than they are for Medicare. And what this means is that policies other than Medicare are spending a lot more money paying their executives and the people that are responsible for processing and sometimes denying claims and then justifying those denials. Private insurance does that at a higher rate than Medicare, and they invest a lot more money in that end of things. However, even if you brought all of insurance down to a cost level that Medicare is currently at, you're not saving that much money. The majority of healthcare costs that get inflated in the United States, survey after survey has shown the same thing, that other developed countries like Australia and Japan and South Korea and Denmark and Norway that have healthcare systems that have much better outcomes than the United States, one of the reasons that their healthcare costs are so much lower is they have much lower rates of obesity and they have a higher rate of scientific literacy in their population. And they have a lot more preventive care woven into their healthcare system. And they have big caps on how much different entities can profit. So if you look at item for item differences in things that are done in hospitals, a given hospitalization, an ICU stay, an MRI done in hospital, or a cardiac stent, Each of these is much less expensive in those other countries than it is in the US, and it's utilized far less often. So, if we want to rein in healthcare costs in the United States, we have to tackle it from a multitude of angles. And I think what we need to do is find ways to pull the profit incentive out of people being sick and getting treated for problems as they emerge over and over and over again. Entities in our system right now, like hospitals and pharmaceutical companies and medical device companies and even medical practices, profit a lot more from having a relatively sick individual who needs care over and over and over again than from intervening early and trying to prevent that individual from becoming sick. I think that needs to change. And I think there are some ways we can start to do it. And the first thing is to move away from what we call a fee for service model. The majority of healthcare in this country right now is delivered where the practice or hospital or imaging facility that is providing care bills the insurance for a specific procedure, whether that's an office visit, a medical consult, an imaging procedure, a cardiac catheterization, or some other kind of surgical intervention. And there is a set amount reimbursed by the insurance that is in part set by a big Medicare utilization committee that is loaded with physicians who are in the medical specialties with only a handful of primary care people. I think moving to a model where you have something that is closer to the direct care practice that I worked in at the very end of my stretch of clinical practice would be much better. In that model, for primary care, you are paid a set amount based on the age and maybe even the general disease profile of the patient, right? So if I have a 22-year-old with no prior health diagnoses, that is going to reimburse at a lower rate than a 60-year-old who has known coronary artery disease, diabetes, hypertension, hyperlipidemia, because that 60-year-old, I need to watch a lot closer. I need to bring them in more often and manage them more aggressively than I do that 22-year-old. The 22-year-old, I may only need to see twice a year, even if those need to be longer visits so we can really delve into preventive care and I can talk about how they're eating, what kind of activity they're getting, and try and really make sure that they're up to speed on the things they can do to optimize their health at that young age going forward. What kind of vaccines are appropriate? What kind of preventive screenings that are appropriate? What kind of things they have to look out for to say prevent early colon cancer? To harken back to a short video I did this morning. These things are all incredibly important. And I think if we start tailoring our healthcare system so that physicians are spending more time on preventive care, they have more time with patients. When I was in fee for service practice and my practice was at its absolute peak, I had 2,500 active patients. This means that there invariably was a real problem getting somebody who came up sick or suddenly developed abdominal pain or really had a very nasty respiratory infection and couldn't breathe. It was very hard for me to get them in same day. I could still frequently do it because I did backflips trying to tailor my schedule to be able to do it, but it was hard. When I moved to direct care, my practice capped at 600 patients. And towards the end, as my practice built, I was just over 450 patients. I very easily could get anyone who needed to be seen acutely in within one business day, very frequently on the same day. It's a much better model. It also gave me a lot more time to sit down with patients and do real preventive care. And when I was treating musculoskeletal pain patients and doing manipulative interventions, I had time to start to talk about individual exercises they could do to start to retrain their muscles to be able to control them better and prevent further problems going forward. That is the model I think we need to move to. And we can do similar things with specialties where you have set reimbursements for a given surgery that includes both the surgery and the entire recovery period and all the rehab that's necessary. I think those kind of things can be done. That system can be structured. And when you start to tailor the payments based on the physician doing certain things that lead to better preventive care and better outcomes. For instance, in primary care, if you have a hypertensive patient, are you talking about all the appropriate lab screenings they need? Are you talking about vaccinations that can help prevent disease down the road that they might be at slightly higher risk for if they're obese and if they're having other problems? Each of these things can be documented. Are you documenting nutritional counseling 4 times a year? Are you documenting activity counseling 4 times a year? All of these things could be used to tailor reimbursement. And the practices that are taking the time to do these things can make just a little bit more money. And that puts our incentive structure into preventing illness instead of waiting till people get sick and treating it. That's what I see as the model that we need to move to if we're going to get the kind of outcomes we want long term. And if we're going to change the experience of interfacing with our healthcare system to one that is more positive for patients, where they feel like their physicians are listening to them, taking the time that they're truly heard, addressing their concerns. And when they come in asking for a specific test that isn't appropriate, they're taking the time to explain to them, hey, look, this is a can of worms and this is why. And you don't want to go down this rabbit hole. So that's what I think a better healthcare model looks like. And now, if that were implemented along with Medicare for all, well, then maybe we have something. But I just think putting in Medicare for all by itself is going to leave a lot of us with a bad taste in our mouth. And it's going to lead to some of the same access to care problems we see in Canada and the United Kingdom, where it takes a long time to get in with primary care physicians very frequently. Well, I'd like to end by asking you, what do you think? What kind of experiences have you had in healthcare, good and bad, that you think play into some of the ideas I have? Either things that where you think what I'm suggesting will help solve a problem that you encountered, or ways in which it might fall short. I want to know. I want to get a discussion going here and see if we can bounce off ideas and come to something that we could all push to our legislators and see if we can get something done that makes for a better future for all of us. I look forward to hearing from each and every one of you. That's it for me today. I'll see you again next time.